Everybody, thank you, Mr. Chairman, and I would like to thank the organizing committee for giving me the opportunity to present on this conference. So I have no conflict of interest to be disclosed. Now, when the patient presents for aortic root replacement, usually their presentation is in one of two forms. The first one is aortic regurg, and the second one is aortic aneurysm, aortic root aneurysm. So it's very important to know what is the pathway when the patient comes and how to reach to the diagnosis, and then how to decide if the patient will get valve-sparing root procedure or not. So if we start with the aortic regurg, there's three types of aortic regurg according to the classification by Professor Jibreen Al-Khouri, and only one of them is suitable for valve-sparing aortic root procedure, and this is type 1B. And in these cases, classically, the aortic root will be dilated or aneurysmal, and the aortic valve leaflet will be normal, with or without an ascending aortic aneurysm. So we start by looking at the echo, and we'll notice that the jet in the aortic regurg is central jet, and the morphology of the leaflet is normal with dilated aortic root with effacement of the ST junction. And then we go to the CT scan to verify the presence of the aneurysm in the aortic root and the size of the aortic root. And this is one of the important steps, because if you have an aortic root that is normal in size or slightly dilated with severe aortic regurg, then you will know that there is something else other than the aortic aneurysm that is causing the aortic regurg. So we start with the aortic regurg, and then we confirm if there is aortic root dilatation or not. If there is no aortic root dilatation, it means that there is another problem. There's either leaflet problem or annular problem. So that patient will need aortic valve repair or aortic valve replacement. If there is an aortic root dilatation, then we have to make sure that the leaflet morphology is normal. If the leaflet morphology is normal, then this patient is going to be candidate for valve-sparing aortic root procedure. If the leaflet is abnormal, then this patient will probably end up having a Bintal procedure. If the patient presents in another way, if the patient presented with incidental finding of CT scan of having aortic root aneurysm, and he had the CT scan for any other reason, or some patient will present with non-specific chest pain, they will get the CT scan to rule out pulmonary embolism, and they will find an aortic root aneurysm. Then you have to do an echo and look at the aortic valve. If the aortic valve is stenotic, then this patient will need a Bintal procedure. If the aortic valve is, the patient have aortic regurg or normal aortic valve, then we look at the leaflet morphology. If it is abnormal, then we go for Bintal. If it is normal, then this patient will be a candidate for valve-sparing aortic procedure. So it doesn't matter whether you start with aortic regurg or aortic aneurysm. The bottom line is you have to have a dilated aortic root, you have to have normal morphology of the leaflet. When we talk about the valve-sparing aortic root procedure, there's a number of technical details that we have to pay attention to. The first point is whether the valve is tricuspid or bicuspid. The second point is the patient going to have remodeling or reimplantation procedure. The third point is how to size the graft. And the last point is the commissural orientation. So if you look at severe classification for the bicuspid aortic valve, there's type 0, type 1, and type 2. And type 0, there will be no confusion with tricuspid valve because we have two equal leaflets, and they're really balanced. But the confusion comes when you have type 1 or type 2, and you have to have a very good cardiologist to look at the echo and do a transphageal echo and make sure that this is really bicuspid valve. And the commonest type is type 1, representing more than 85% of bicuspid valves. The difference between type 1 and 2 is when type 1 have two real commissures, as you see in the right-sided picture in the middle, two real commissures and one commissure with a fused raphe. While type 2 have two fused raphe, so it looks like a type 0, but actually there is thickening and fusion of the cusps. Why is this important? If you look at the association of aortic aneurysms with bicuspid valve, you'll find that both ascending and root aneurysm are more associated with type 2, and the involvement of the ascending aorta is more common than the involvement of the aortic root. And if you look at the result of valve-sparing root procedures when it is done for tricuspid versus bicuspid valves, the durability on the long term is better with a tricuspid valve than bicuspid valve. The second point is the patient going to get remodeling or reimplantation? So in remodeling, the difference between them in remodeling procedure, you will tailor the shape of the graft to the shape of the sinuses, and you'll keep the commissures and you'll implant it in between the sinuses. While in the reimplantation procedures, you have two layers of suturing. The first layer is you take the straight graft, you'll implant it at the level of the annulus, and then you'll fix the commissures inside that graft. The remodeling procedures was described by Professor Yaqub, and there is no really fixation of the ventricular aortic junction. The durability is not reproducible. If you look at the series of Professor Yaqub himself, the long-term durability in 15, 20 years is 90%. But that was difficult to be reproduced by other series. But the reimplantation procedure described by Professor David, you have fixation of the ventricular aortic junction, and it has reproducible durability regardless of the place where it was done. And that's mainly a selection bias. In remodeling, you have to have really good selection and select the right patient to get the remodeling procedure. If you select the wrong patient, then it's not going to be a durable procedure. While in reimplantation, you can do it in any patient who have a dilated aortic root and an aortic regurg, normal leaflet, it's going to work. It does not need selection. The third point is the sizing. There's different ways that is used by different surgeons, but the most common and reproducible one is the height of the commissure, which is the distance between the deepest point of the sinus to the commissure. And that will tell you what is the size of the graft that you need to use and what is the height of the sinus that you need to create. The last point is the commissural orientation, and we'll start with the tricuspid valve. There's two types of orientation that's common, the 120 degrees orientation, and the 150, 60. So the best way to decide what orientation is going to make the valve competent is when you open the root, before you excise the commissures, just look at the native orientation of these commissures. Remember, the main problem in this patient is a dilated root. If the patient had problem with the other problem other than dilated root, he would present early in life. So just remember, when you open the sinus, to look at the commissures and their native orientation. And then try to simulate the same thing in your new graft. This is as a starting point. This is not the final decision. So if you notice that the patient have a 120 distribution, then once you fix the commissures inside the graft, put it in the same orientation. And then look at the level of the tips of the leaflets. If all the three leaflets meet at the same level, then you stop and you fix the commissures. If one of the leaflets is higher, it means it is stretched. So you have to bring the two commissures around that leaflet close to each other, and that will depress the leaflet to come at the same level of the other leaflets. If it is the other way around, if the leaflet is too low, then what you need to do is to stretch that leaflet that is low by putting the commissures away from each other, and that will elevate that leaflet to meet the other two leaflets. Bicuspid valve is different. If you have a type 0, then it's a no-brainer. You just put it 180 orientation. But difference in bicuspid valve, that the first thing you have to decide, are you going to do any additional leaflet procedure by shortening the leaflet or transfixation of the leaflet? If you have type 1 or 2, then again, you have to look at the native orientation, and your starting point is 180. So once you do the leaflet repairs, any additional leaflet repair that is required, you stretch the leaflet, the commissures at 180, and you do the same exercise, and you look at the reference leaflet with the other leaflet, compare the point where they meet. If the reference leaflet is higher than the other long leaflet, then you have to do the native orientation by bringing the reference leaflet commissures close to each other. If you have a very good competent valve with the 180 orientation and both leaflets are at the same level, then keep them at the 180 to simulate the type 0 bicuspid valve. How is that important? If you look at this study, it compared the native orientation versus the 180, and there is no difference. And this is well understood because there will be no difference, because by the time you orient the leaflet and the OR, if you come with non-competent valve, you are going to come back and fix your orientation or replace the valve. So all the patients will come out with competent valve at the end. So when you look at the long-term follow-up, it's going to be the same. So commissural orientation is important, but it's not going to show up in the follow-up results. Now we'll talk about the result of the valve sparing procedures. And this study from Siever's group in Germany, they looked at the result in 1,015 patients of valve sparing aortic root replacement. And one of the issues when you look at survival is very different. Very difficult to detect any differences in survivals in procedures like that. So here they looked at the survival of those patients compared to the age-matched population, and they found no difference. When they compared the tricuspid valve and bicuspid valve, there was no difference. But this is in the hands of experienced people. When they looked at the aortic regurg at the discharge, if the patient have no aortic regurg, is it better than having some aortic regurg? So there is tendency toward worse outcome if the patient leaves the hospital with some degree of aortic regurg. And this study did not reach statistical significance, but the trend is clear. They compared Marfan to non-syndromic patients, and they found no difference. But that could be a representation of the small number of Marfans in that study. Now, we know from other literature, if you need to do any reconstruction procedure or any additional repair procedures in the leaflet, that can affect the result of the outcome. However, in this study, it did not translate into a difference. When they compared David reimplantation to Yakub remodeling, there was no difference between these two procedures. But again, this is a selection issue. So if you select the patient well for remodeling procedures, it's not going to show any different outcome than reimplantation procedures. Again, from the same group in Germany, Siever's group, they compared the valve sparing procedures in tricuspid and bicuspid valves, and they found that the reimplantation and remodeling has no difference in survival. However, if you look at this graph, up to 10 years, there was no difference. But then after 10 years, the graphs start to separate. But also, there is low number of patients who are being followed. So this is something to keep in mind. The same happened for the bicuspid and tricuspid valve. In the first 10 years, there is no difference. But then after 10 years, they start to separate. This study looked at the patient with bicuspid aortic insufficiency and compared root reimplantation to Bintal procedure. And there was no differences in the outcome in those patients, post-operative outcomes. And when they looked at the survival, the freedom from mortality, and the freedom from reoperation, and freedom from significant AI, it was all the same. So doing a bicuspid valve-sparing root procedure versus a biological valve, there is no difference. The study again compared the bioprosthetic valve conduit to valve-sparing aortic root procedure, and it showed that it has the same freedom from significant AI with long-term follow-up. The bioprosthetic valves after 8 years tend to have less freedom from reintervention. However, there's no differences in survival between the two groups. This study again looked at the patient who have valve-sparing root procedures versus the Bintals, and in this specific study, the authors have, with time, they were doing more biological valves and more valve-sparing procedures than mechanical valves. And if you look at the post-operative outcomes, all of them are equal except 2 points, which is the chest tube drainage and the number of transfused packed RBCs. And this is worse in patients with mechanical roots. And that explains why they shied away from doing mechanical roots and they went to biological roots and valve-sparing root procedures. This is an interesting graph showing that the survival of patients who have valve-sparing root procedures is equivalent to age-matched population. And the survival is better than both biologic and mechanical roots. And in the table here, you find the 5-year survival of valve-sparing procedures, 97%, compared to 91% with mechanical roots and 81% in biological roots. So you have better survival in valve-sparing procedures, and you have more bleeding in mechanical Bintal procedures. So in summary, the valve-sparing aortic root replacement is feasible in both bicuspid and tricuspid valves. However, it seems that it's more durable in tricuspid valves. The reimplantation valve-sparing procedures seem to have more predictable outcomes than remodeling procedures. We should avoid remodeling procedures in patients with annular ectasia, Marfan's, or connective tissue disease, and those patients probably will do better with the reimplantation procedures. Orientation of the commissures depends on the level of the leaflets when the commissures are stretched. And the comparison between the valve-sparing procedures and valve conduits depend on the sex and age of the patient at the time of implantation. So there is no general rule of valve sparing is better or bioprosthetic is better or mechanical is better. We should tailor it to the right patient. Thank you.